A very good morning to all of you. I'm Dr. Farendra Bhardwaj, working as Associate Professor in the Department of Obstetrics and Gynecology. Now today I'll be presenting and discussing in front of you is the medical management of endometriosis. So we all know what is endometriosis is endometrium which is growing outside the uterine cavity. Basically this endometrium creates an inflammatory reaction, and all this inflammatory reaction is the cause of basic pathophysiology of the cause of all these symptoms of endometriosis. The common symptoms are dysmenorrhea, dyspareunia, and chronic pelvic pain along with infertility. Now what is dysmenorrhea? Is a severe pain during the menses. Dyspareunia is a pain during the sexual intercourse, and chronic pelvic pain when a patient is having a lower abdominal pain continuously. Infertility is by definition is inability to conceive by a couple having a regular intercourse and unprotected regular intercourse over a period of 1 year. So all these things could be because of the endometriosis. So this is what we commonly call as a triad of endometriotic symptom is dysmenorrhea, chronic pelvic pain, and infertility. If we go into the etiology, retrograde menstruation is one of the most accepted theory, which means there is a menses which is coming through the vagina as well as through the fallopian tube into the peritoneal cavity. Various other theories, coelomic metaplasia, metastatic spread, altered immunity, stem cells, and genetic theories have been proposed. What we need to understand is coelomic metaplasia theory. It's one of the important theory which says that there is a undifferentiated cells into the peritoneum which convert it into the endometrial cells and produce the symptom of endometriosis. Diagnosis, commonly the diagnosis, yes, there is a delay between the onset of symptom and the diagnosis of around 7 to 10 years. Common modalities are USG, MRI. The one which can tell you the structural abnormalities into the pelvic organ. Yes, CA125 is also one of the marker of peritoneal inflammation, which is raised in case of endometriosis, and laparoscopic surgery by which you can directly see the endometriosis. So we come to the topic of medical management. The aim of medical management is to reduce the pain and increase the possibility of pregnancy, along with there should be a minimal reoccurrence of the disease. Other modalities to achieve this or objectives are surgical modalities, counseling, and infertility treatment including IVF. So if we go to the medical management, the first line is non-hormonal, which includes NSAIDs, hormonal is progesterone, OC pills. Second line is again GnRH, IUCDs, and non-hormonal like analgesics, opioids. If we go to the analgesics, NSAIDs, whenever a patient is getting pain, what we give is mefenamic acid, mephtal spas, commonly using drugs, but other drugs are paracoxib, refocoxib, or the other NSAIDs which are selective COX-2 inhibitors. OC pills is one of the way to reduce the symptoms by suppressing the ovulation. It reduces the cyclical pain of the patient, and it also helps in reducing the generation of prostaglandin. Progesterone, as we say, it's endometrium. By giving high doses of progesterone, it causes desudalization of endometrium, and by desudalization of endometrium, there is a atrophy of the lesion, and it causes less in pain. Newer molecule of Dynogest, which is another 9-to-not testosterone derivative, which acts like a progesterone and as well as has got an anti-androgenic activity. It's a newer molecule which we are commonly using in cases of endometriosis. LNG-IUCD works like a progesterone, but it is a device which is kept inside the uterus and gives a continuous low level of progesterone in the body and works like progesterone. There is certain role of MIFEPRISTONE, which is basically a progesterone antagonist, which produces amenorrhea and reduces the pain. Other drugs like danazol, gestrinone works well in cases of endometriosis, but we have to individualize the therapy depending upon the patient's symptom and clinical profile. GnRH agonist as a drug which produces action like a GnRH, which is persistent, and it causes pseudo-menopause like state. So when there is a menopause, there is a suppression of the lesion, and we feel like that it can be one of the way by which you can reduce the pain as well as the disease progress. But if we are giving GnRH, we need to give add-back therapy because it reduces the estrogen and progesterone. So low doses of estrogen and calcium and vitamin D is advisable when we are giving GnRH therapy. GnRH therapy can be given 3 doses of debut preparation monthly, 28 days apart, is sufficient many a times. Another drug is aromatase inhibitor, works well in case of endometriosis. The commonly used drug is LETROZOLE. newer treatment like selective estrogen modulator or relaxofane, progesterone receptor modulators like urylipristal acetate, all of them work in cases of GnRH. Again, another drug is another treatment is non-hormonal therapy, where we use an immunomodulator like pentoxifylline, anti-TNF-alpha like infliximab, and anti-androgenic drugs. So which drug to choose? Because we have discussed so many drugs. So in cases of mild pain, you can give NSAIDs. Common use is paracoxib and Reloxi, and Meftal spas are another line of drugs. Then, if depending upon symptom and age of the patient, you can give combined ocipils and progesterone. If the treatment fails, you can consider giving GnRH, danazole, but these drugs have their own side effect, and we have to individualize the therapy. So thank you so much for your patience listening. Thank you.